Hi everyone, so happy to be here today. I am David Bauer. I'm a pediatric neurosurgeon at Texas Children's Hospital. I specialize in Chiari and spine surgery, including spine fusion and scoliosis. And today I was asked by the Bobby Jones Chiari and Syringomyelia Association to speak about cervical spine fusion and Chiari malformation. And so hopefully today we'll be able to go through a few high-level points in this topic, including the background and causation of Chiari I malformation. We'll talk about the basic anatomy and physiology behind Chiari I. I think it's really important to understand the physiology so that if you do have symptoms, you understand where they might be coming from. We'll talk about a term called complex Chiari. It's very important to understand this. This is not everyone with Chiari, but a few people who have Chiari have complex Chiari. What does it mean? And if you have complex Chiari, there is a chance you may need a fusion, a cranio-cervical fusion. We'll talk about that. And then we'll talk about how spine instability is treated in Chiari malformation. So I always throw up this picture. This is Hans Chiari. This is the person after whom Chiari is named. He's a pathologist who worked in Vienna and Prague. He was not a surgeon. He did not treat any patients with Chiari, but he did describe autopsy cases of patients with Chiari. And then there's a Dr. Arnold who described a similar finding, and so that's why sometimes we call it Arnold Chiari malformation, but most people these days just call it Chiari malformation. So what does it look like if you don't have Chiari? And so this is a patient who doesn't have Chiari. You can see the nose, the back of the head. You can see the cerebellum, which is this structure. You can see how it's rounded. There is white, which is spinal fluid and back. And here's a slice through the middle part of the brain, and you can see these are the ventricles, the fluid-filled cavities of the brain. And this is a patient with Chiari, a 16-year-old boy with headaches in the back of the head with activity, or coughing or sneezing. So this is a typical Chiari malformation. You can see the cerebellum here is not rounded, however it's pointed. You can see how it's pointed. And part of the cerebellum goes below the bottom of the skull, which is here. And anytime more than a few millimeters of cerebellum is below the bottom of the skull, we call this Chiari malformation. Now, this patient has a normal connection between the skull and the spine, and this is important when you see some pictures in a few slides. So this is Chiari II malformation. This is a patient with spina bifida, or a term called myelomeningocele. So only patients with spina bifida have Chiari II. And in this structure, the vermis, which is a different part of the cerebellum, gets pulled down, as well as the brainstem. And that's what causes symptoms. And Chiari goes hand in hand with Syringomyelia. So not everyone with Chiari has Syringomyelia, but some patients with Chiari do have a syrinx, and so we typically get imaging of the spine to look for a syrinx, and you can see the fluid in the spinal cord. And we feel that the most likely cause of the fluid is blockage of the flow of spinal fluid from the Chiari, and fluid is pushed into the spinal cord, causing it to expand and potentially injure the spinal cord and cause symptoms. So what causes Chiari malformation? Well, Chiari I malformation might be caused by a few different things. We think multiple things could be the cause. It could be a small posterior fossa, which is the back part of the skull, back here. And so if it's too small, then part of the brain comes down or herniates down. It could be overgrowth of the cerebellum. This means this structure might grow larger than maybe it's supposed to, and it causes Chiari. You could have hydrocephalus, which is elevated pressure in the head, push the brain down, causing Chiari, or you could potentially have spinal fluid leaking out from the spinal canal and pulling the brain down, causing Chiari. A Chiari II malformation we feel is congenital. It's something that happened in utero from spinal fluid leaking from the spina bifida or the myelomeningocele and pulling down the brain during growth and development. So what imaging is needed if I do have Chiari? Well, we typically will order an MRI of the brain, looking for hydrocephalus, a tumor, another mass. We'll look at the spine, MRI of the entire spine, looking for Syringomyelia, potentially tethered cord or some other structure that might be abnormal. And then we'll possibly get a CT of the cervical spine if we believe that some of the bones in the neck are abnormal, and possibly a dynamic imaging, which means some sort of image where you move your neck forward and backwards. We call it flexion and extension, to see if the bones are moving abnormally. This can be a CAT scan, an MRI, or just some x-rays. So what symptoms might improve with surgery, and what might cause these symptoms? Well, for Chiari I malformation, the typical symptom is headache. Maybe 75% of patients have headaches, usually in the back of the head, that get worse with activity. This might be sports, it might be coughing, laughing, sneezing, and we call it an occipital Valsalva-induced headache. That's the medical term. You could have brainstem symptoms, so this is compression of the brainstem, and you can see the brainstem here in this picture, and that could be abnormal eye movements, problem swallowing, intractable vomiting, weakness, or you could have syringomyelia, and that's fluid in the spinal cord, and that can cause sometimes shooting pain into arms and legs, weakness, incontinence, a variety of symptoms. For Chiari II, the symptoms are typically brainstem symptoms, neck pain or headaches, and often the syrinx. So who might benefit from surgery if you do have Chiari malformation? Patients will benefit if patients with symptoms will benefit from surgery. So this is a true statement. If you have symptoms and we believe that the symptoms are directly related to the Chiari malformation, then we can do surgery to treat the Chiari malformation and the symptoms will get better. But it's also true that patients without symptoms do not need surgery. And there are many patients that I follow in clinic and my colleagues follow in clinic who have Chiari malformation, and it's found incidentally maybe after a sports concussion and the child gets a scan of the head. And if the child has no headaches, no symptoms referable to Chiari malformation, then there's no need to do prophylactic surgery to prevent bad things from happening. But the problem is determining what symptoms are related to Chiari can be very challenging. And you can have headaches for a variety of other reasons, such as migraine headaches or seasonal allergy headaches. And symptoms unrelated to Chiari will not get better if you have surgery. And so as a surgeon, I do not want to operate on a patient and put a patient through the risk of surgery for a type of headache that won't get better with surgery. And again, there's no need for a prophylactic surgery for Chiari. So I'm going to go over a couple studies. These are longitudinal, so basically long-term studies looking at multiple patients. And this is by Dr. Oakes in one of our reputable journals, Journal of Neurosurgery. And so of these 500 patients, 40% presented with headaches, 18% with scoliosis. But the important thing, 4 patients needed cranio-cervical fusion. So in this series of patients, he found that 4 patients out of 500 needed a fusion in order to have symptom relief. Another very large study, this is a Park-Reeves study looking at complications and outcomes. And this is a study from multiple hospitals, multiple surgeons provided patients. And so when that happens, we feel the data is probably better quality, higher quality than in smaller studies. 692 patients. And in this series, post-op cervical instability, that means patients that have weakness between the skull and the spine and might need a spine fusion, 4 patients out of 692 patients. So that's really not that many patients. And this leads us to complex Chiari. And why is this important? So complex Chiari, the term came about because we found that some patients had Chiari plus additional anatomic problems between the skull and the spine. And this could be the skull settling on the spine, so we call this vertical instability, where the skull settles down on the spine, or the spine could have abnormal joints between the bones or fused bones. The skull could be poorly attached to the spine with looseness. We call this horizontal instability, or the spine could be pushing into the spinal cord or brainstem causing symptoms. And there are a few publications that characterize this. You can see this picture here. This patient has Chiari. And you can see this bone, which is the second bone in your cervical spine. That's the spine in the neck. And there's looseness between the first and the second bone, and this bone is pushing backwards and potentially compressing the brain. And you can imagine how that could potentially cause symptoms. Another way that symptoms could happen would be if the angle between the skull, this is the bottom of the skull, and the top of the spine becomes acute. So you can see when the angle becomes acute, then this is the brainstem, and you can see how it's stretched and potentially compressed by the spine, and that could potentially cause problems. A publication came out in 2020 looking at other ways of trying to measure these complex relationships between the skull and the spine. And you can see in this picture, this is a demonstration of basilar invagination, and so you have a relatively normal angle, but if the skull, which is depicted here, settles on the spine, you can see how the spine could push into the brainstem and cause symptoms. Or if the spine basically rotates backwards and compresses the spinal cord, which is coming through this location, then you could have symptoms. And so I'm going to show a few pictures to hopefully better illustrate this. I know these are complex topics, but these are the topics that surgeons are talking about at national meetings. And so I'll show a few pictures of patients with a few of these different problems, and hopefully it will make a little bit more sense. This is a 16-year-old boy. He has activity-related headaches. So every time he goes out and plays soccer, he has headaches in the back of his head. And you can see here that he has Chiari malformation. So this is the cerebellum that's pointed. It's compressing. It's blocking the flow of spinal fluid through the brain to come around the brain to get reabsorbed. And so when he has headaches, the fluid tries to get out. It can't get out. The pressure goes up in his head, and he gets a headache in the back of his head. This is a 1-year-old boy with motor delay. So you can see this patient has Chiari malformation, but this looks very different than the last patient. You can see that part of the spine is pushing backwards on the brainstem. You can see how it's curved and compressed, and you can imagine this boy might have different symptoms and might need a different treatment than the first boy. This is a 1-year-old girl with poor feeding. So you can see the nose here, the back of the head. You can see this looks also very different than the last two images. You can see the Chiari malformation, which is here, but also increased fluid in the brain. And so this patient may need drainage of the fluid rather than treatment of the Chiari. And this is a patient, a 7-year-old boy with a spinal fusion and Chiari with headaches with sports. And so you can see here with this x-ray that this bone, which is the second vertebrae in the spine, and the third bone here, which is the third vertebrae in the spine, they're fused together from birth. And you can imagine that with Chiari and this configuration that maybe the patient might have instability or another problem besides the standard Chiari malformation. So we call this complex Chiari. And this is also a patient with Chiari, and you can see how this looks, again, very different. So when we look at other patients where the bottom of the skull, which is here, has a more acute, obtuse angle, and it's coming straight up, you can see how this acute angle, almost 90 degrees, causes very severe compression of the brainstem, and this patient may need a different treatment for symptom relief from Chiari. So what about the spinal instability in Chiari? So there have been a few publications on this. One of the early ones was in 2015 by Dr. Goel from India, and he talked about treating Chiari malformation with a procedure called a fusion. So this is where we put screws into the bones in the spine so they can't move, and then some bone grafts so the bones will heal together. With the idea that abnormal motion was causing symptoms from Chiari. And so this is a picture from his publication, and you can see that many of these patients have very abnormal bony configurations. Just about every patient in his series. So these aren't the patients with the standard type of Chiari malformation that most people have. These are atypical. You can see fusions between the bones, and you can see the screws that he put into the bones to heal them together. So it's possible there may be some patients, a subset of patients with Chiari, that have an abnormality like this that may need to be treated with a fusion. And so if so, then how do we determine who might need fusion? This is very important because fusion adds additional risk to treatment to a patient. Again, the typical treatment of Chiari, I hadn't gone over it earlier, but is decompression. So this is removal of bone and maybe sewing in a patch to give more room. But in some patients with the abnormal movement, we need to know this and often ahead of time, and so that we can possibly do a fusion surgery instead of the decompression or in addition to the decompression. And so this is a depiction of flexion extension imaging. You can see a patient moving the head forward and backwards. This is from a publication from 2013. And you can see the MRI. And this is a type of imaging that I use quite often to determine which patients may benefit from fusion, and it's called a flexion extension MRI. And you can see when the child's head is flexed, you can see the chin coming down to the chest. You can see how narrow and compressed the spinal cord is. Whereas when the child extends, you can see how the space opens up a little bit. And so this child then went on to receive a fusion, and symptoms improved. When we talk about fusion, and I'll get into some of the technical aspects, I think this is important because not every surgeon does a fusion in the same way. And there are some technical aspects of how to do the fusion, how to put in hardware, and whether a fusion will actually happen if you've done a fusion. Not every patient achieves fusion, and if that happens, then the hardware may break and pull out, and you could have complications. And so I'd like to go through a few of these techniques so that if you are considering a fusion, or if someone has talked to you about a fusion, you might better understand the nuances of the operative technique. And so if you look down here in the bottom, you can see a couple ways of fusing the spine. You can have little screws in the skull, and then typically you'll have little rods coming down to additional screws that are in the spine. You can potentially put wires in to also add some more stability. You can put a piece of bone graft in to have the skull heal to the spine. This is another way of doing this. So you can see a different type of plate. You can imagine if you had a very large plate, at times you could maybe lie back and you could feel the plate. And so that's one of the risks of putting a plate on as opposed to putting something that's lower profile. But we also want stability. If someone's spine is unstable, we want the spine to not move. And so we worry about the thickness of the skull bone. If you're very young, or if you have a genetic condition, the skull bone may be very thick or very thin. There's veins that are deep to the bone, and we want to make sure that we don't hurt these veins. If someone has had a Chiari surgery and already had some bone removed, then that may make it challenging to find a good place to put a plate or fixate the skull. These plates also can be irritating at times. Sometimes when we put these rods in, they can be challenging to put in, and so there are a lot of technical nuances that we think about. Here's a publication from my hospital that looks at a sort of a new way of doing this type of surgery, and you can see the instrumentation is low profile. The screws go into the skull, but from sort of a lower position, so it's much easier to put in the rod, and it's much easier to have a sort of a lower profile system. And so a few people have done something similar in the past, and these are screws that go into the occipital condyle, or that go through the first vertebrae up into the occipital condyle. So it's been shown to be as strong, if not stronger, than a plate. And in this series of patients, I used a piece of rib with a little bit of a bone growth factor called BMP to help fuse the bone, and evaluated patients over time to see if they fused and if the hardware broke. And this is sort of how we did it. You can see the screws going into the spine on a profile view. There are a couple structures, arteries that we are careful not to hurt, and the spinal cord comes through the center. And you can see how we have a navigation system to carefully put these small screws through really a very small area of bone safely. And you can see these are the condyle screws, and this is what it looks like. You can see the fusion. So this is the piece of rib that's fused between the skull and the spine. And I had a follow-up publication looking at the technique for fusion, because I had a lot of my colleagues asking me how I was able to get such a high rate of fusion. I found 100% rate of fusion using this technique. And these are some operative pictures that you can find in the article looking at the Chiari decompression in the screws. And we take a piece of rib and split it in half and put the piece of rib down between the skull and the spine. And the screws are put in like this with a navigation system, so that we have perfectly placed screws each and every time, even though we can put in very long screws to hold the spine together. And you can see what it looks like on a scan, where you have a long screw holding the spine together, and then you can see the rib graft, which is really fused very nicely. You can see in this picture how nice the rib is fused. And this is a patient where we placed the hardware and had to remove the hardware, and you can see the very nice fusion. This is the piece of rib on either side that's fused. And so many of my colleagues now use these techniques to perform fusion because it has such a high rate of success. We can use it in different ways. These are some patients where I had to remove a tumor from the bones, and you can see the rib graft for the fusion and the hardware. So I'm going to go through a few patient examples. Hopefully that wasn't too technical, but I do think seeing what this hardware can do and what types of patients might benefit from spine fusion would be very helpful. And again, these are patients that they all have problems in addition to the typical Chiari malformation. So here's a case, a 15-year-old boy who has a genetic syndrome, had prior skull surgery. You can see some sort of open spots in the skull, has a shunt, which is a tube from the brain to the abdomen draining fluid. And he came in with some new weakness and problems with sleep apnea. He wasn't breathing at night. And you can see this picture here, where part of the skull, which you can see many of the bones have been fused together, is coming up into part of the spine is coming up into the skull, and you can see it's compressing the spinal cord. It's causing injury to the spinal cord. And the pictures didn't look like this a few years back. So he has settling of the skull onto the spine. This is spinal instability. And so the treatment is to lift the skull up to an anatomic position so it's no longer pushing on the spinal cord, and then hold it in place and make it heal so that he won't have these new some very significant symptoms. And so this is, what I do is an intraoperative reduction. So we lift up on the skull, and you can see how going from this position to this position, you can see how this bone was pulled out of the skull. And once it's in an anatomic location, then I put in screws and rods into the spine to hold things together so the spinal cord won't be injured. And so you can see the screws and the rods coming together, and how the spine is basically holding the head up above the spine so that the spinal cord is not compressed. Here's a second patient, somewhat of a similar problem, an 11-year-old girl with a genetic syndrome who also has basilar invagination. And you can see how the bones are fused together from birth. You can see how this bone is coming up into the skull and pushing on the spinal cord. And so you can imagine that can cause symptoms. She came in with sleep apnea. She wasn't breathing at night. Her oxygen level was going down and weakness. And I was able to fix this by lifting up the skull and then putting in these 2 screws that basically came across the fused bone up into the skull, and it held the skull in place. This was very nice because I didn't need to put in a tremendous amount of hardware, and the rib graft here, you can see how it fused very nicely between the skull and the spine. So she achieved the fusion that she needed to have to be safe. And finally, I'll show another case. This is a patient with Down syndrome and had small Chiari with instability. And you can see that really the main problem is the top of the spine is pushing into the spinal cord. And you can see how there's a gap here, and the spinal cord is coming down in this location. And the bones were very small. Again, this is a 2-year-old patient. And some of the arteries were in sort of abnormal locations, and so it was challenging to find a location where I could put in screws to hold things together, but she needed this so that she wouldn't become weak. And so you can see how I was able to get things aligned and then put in these complex screws using a navigation system to hold everything in place. And she got better, her sleep apnea went away, and weakness improved. Well, today I hope I did a good job going through complex Chiari malformation. So this is really not your typical Chiari malformation where some of the brain is coming through the bottom of the skull, but all the bones are normal, and a patient just has headaches in the back of the head with activity. Patients with this problem can very easily have something called a Chiari decompression. It's the bone removal and sewing in a patch, and the symptoms should reliably go away. But today we talked about patients with complex Chiari. So this is where the skull and the spine are loose, the bones are maybe abnormal, the skull is settling on the spine. So it's Chiari plus these additional issues. And we went through some of the ways to treat complex Chiari. So this is the spine fusion and some of the techniques of how to fuse the spine. I really hope everyone enjoyed this talk. This is my wonderful team who let me really specialize in taking care of patients with Chiari. And I'd like to thank Bobby Jones, CSF, for their patient advocacy and their dedication to research, to finding out the truth and how we can best take care of our patients with Chiari malformation. And I'd love to answer any questions. And I appreciate the chance to talk today.
So I have a question.
Mm-hmm.
Could you address Ehlers-Danlos syndrome and hypermobility, because children are so flexible to begin with, right? And how do you determine if in a child's space they have hypermobility that would cause issues that would possibly need a fusion?
Yeah, no, that's a great question. We think about it. So when the Ehlers-Danlos is a problem, it's a genetic problem with connective tissue, and it often leads to it can lead to a variety of problems with connective tissue in the body, blood vessels and things like that. But you can have something called hypermobility, and that means really being double jointed. So if you take your hand and you can bend your fingers back so that it touches your wrist, you probably have hypermobility. If you've had shoulder dislocations or things like that. And so some patients with Ehlers-Danlos syndrome may have too much motion between the skull and the spine, and it's thought that the motion causes symptoms, and treating that with a fusion could be helpful. For kids, I'll tell you, in my practice, I always look for it, and I'll ask patients, are they hypermobile? I find a certain percentage of my patients with Chiari do have hypermobility. It doesn't mean that they definitely need a fusion, but it does mean that I might order advanced imaging. And this means one of the flexion extension scans, either an MRI or some x-rays, to look for that abnormal motion. I'll also tell them that they may have a chance of needing a fusion, but often if they have symptoms that are just related to Chiari and not to the instability, I might do decompression first. And I would say not every patient where I do a decompression needs the fusion, but it's someone that I might just follow more closely in my practice.
And one more question. So there's been some notes in the literature about not only flexion and extension instability, but also like when you're turning, and they're starting to look at that in the literature. Do you have any thoughts on that perspective?
No, that's a great question. So really the imaging can only be as good as the imaging can be. And I can have a patient do an MRI or a scan with the head turned, but how do I interpret that? And so that's really something that would require a lot more research. I mean, those would be purely experimental at this point. I think I'm a huge advocate for research and for pushing the boundaries. How can we do better? And I think everyone would love to have a definitive study. You get this type of MRI, and I can tell you whether you need surgery or not and what type. But we really aren't there yet. Again, I tell all my patients an MRI is only as good as an MRI can be.
Thank you. Thank you.
You kind of answered it already, but in looking at, if someone comes in with symptoms and they have their MRI and say they have instability, but they didn't get a flexion extension MRI, so with your workup, you would do certain things that may lead you to getting that further imaging. Do you do that for all Chiari patients?
Oh, that's a great question. So, if a patient has, if I see someone with Chiari and he comes in after a sports concussion and has no headaches, and I have a CAT scan and it looks like the anatomy is normal, I'll probably get an MRI of the brain and spine to look for a syrinx, but won't get the dynamic imaging. If someone comes into me with symptoms from Chiari and the MRI looks like a standard Chiari, not complex, and the symptoms are your typical symptoms, headaches in the back of the head with activity, I typically won't get the advanced imaging. But if someone has abnormal sort of connections, so either an acute clival-axial angle, so this is the angle between the skull and the spine, and it looks like the spine is pushing into the spinal cord, or if a patient has fusion of some of the vertebrae from birth, so this is a congenital problem, then I'll typically get the flexion and extension imaging. And in my hospital, I like to get the MRI. I find that I like it that there's no radiation. I like it that I can see the actual compression of the spinal cord. And then I might get a CAT scan looking at the bony fusion to see if there's any other abnormalities, just so I don't miss something. Yeah, great question. Yeah.
Anyone else?
Well, great. Well, thank you so much.
Thank you.